Today we have Dr. Sprenkle giving us a talk on the evolving role of MRI and genomics in active surveillance for prostate cancer.
Thank you. All right, thank you, Cynthia. All right, so I have a bunch of slides. I will get through those relatively quickly, I hope. A chance for, oops, I need to click on. Sorry, I screwed that up. I know how to do it. I got it. So I was just commenting earlier that I was initially going to give this talk in about October, I think. And it's really interesting that I didn't, because on reviewing the literature, again, almost every paper I'm going to present was published in November or December. So this is a really rapidly evolving field in terms of using MRI and especially genomics in prostate cancer. So I'm going to, again, focus on largely some of the most recently published data. So I do have some disclosures, none relevant to this talk, but I am a consultant for Exosome Diagnostics, Augmentics, which is Spacor, and Progenics Pharmaceuticals. We've done some research with them using PSMA-based imaging. So quickly, sort of an overview of what things I'm going to talk about. So why active surveillance? What's the rationale for active surveillance? How do we define active surveillance? What is active surveillance safe? And the key to that, again, is stratification. Personalization with genomics and imaging. And then I want to review the EAU's 2018 position statement on active surveillance that just came out at the very end of the year, and how that's relevant to where we move forward. So as we all know, prostate cancer is a very common cancer. It's the third leading type of cancer among men and women, and the sixth leading cause of cancer death among men and women. This thing requires 2 clicks to move forward. All right, so why active surveillance? The main reason is that historically all prostate cancers were detected. Does anyone know who this is? No? Dr. Weiss knows. Maybe after this, we'll try some quotes and see if you can figure it out from there. But so I believe it's in the 90s that he said this, but the current state of prostate cancer may not be good medicine, but it sure is good business. There are many people making a living from prostate cancer. There are more, sorry, people making a living from prostate cancer than there are dying from it. This kind of illustrates that we may not be identifying the right patients. And a second very often used quote of him is cure possible when talking about prostate cancer? Is cure necessary when talking about sort of low-grade prostate cancer? And is cure possible only when it is not necessary? So that really gets to the point of men with low-grade prostate cancer may not need to be treated. And that is one of the reasons why active surveillance is sort of the answer to that question. Morbidity of prostate cancer treatment. We know about surgery, we know about radiation, we know about all the side effects, and they can be significant and affect almost everyone who we treat for prostate cancer. In recognition of this, thing is pissing me off. In recognition of this, the NIH, Peter Albertson was a senior author on this, came up with recommendations for active surveillance in certain men. And they published this in early 2011, or late 2011, sorry, about the role of active surveillance in the management of men with localized prostate cancer, trying to bring it to the fore in public attention that this is an appropriate management strategy for men with localized disease. However, unfortunately, very shortly thereafter, the U.S. Preventive Services Task Force kind of beat us to the punch and gave prostate cancer screening. So because we were overtreating all these men, internally we were realizing we need to stratify and that try to not treat people who don't need to be treated. USPSTF took a hammer and said, well, actually, we're just going to stop screening and treating everyone for prostate cancer. So a D grade means that there's a high certainty that the service has no net benefit and that the harms outweigh the benefits. So that was the position of the US government and actually pretty astute epidemiologists in May of 2012. Now, fortunately, with new data in 2018, this was downgraded to a C, but still, there's at least moderate certainty that the net benefit is small. And so this, again, is for overall detection of prostate cancer in men. So as Dr. Shulam and I have said multiple times, we need to transition from screening to treat. So not everyone that's diagnosed with prostate cancer gets treated, to screen to detect. We want to find out who has prostate cancer, and then we make our stratification for who needs treatment or not. And active surveillance is really the backbone of non-treatment for these men with lower risk prostate cancer. So what is active surveillance? This is published in JAMA in 2017. This is sort of a patient-focused, but also provider-focused sense of what is active surveillance and how it's described. So you get a test, you get diagnosed with prostate cancer, and you go on active surveillance. So it involves regular testing and assessment of signs of cancer progression. So if disease is stable, you stay back in that testing mode. And if we see disease progression, then we can proceed to active treatment. And here it says consider treatments such as radiation or surgery. And the schedule of active surveillance testing, this is a recommendation, but a diagnosis, we definitely use a PSA test, a digital rectal examination, and prostate cancer biopsy. And then repeat biopsy varies, the duration, we'll talk about all of these things. So the active surveillance inclusion and follow-up criteria vary pretty dramatically across institutions. Some of the initial institutions that began with active surveillance programs you can see here. So Sunnybrook is up in Toronto, Hopkins, UCSF, Prius is a big European multi-center group, Royal Marsden is in the UK, and the University of Miami. So these are some of the biggest active surveillance studies. They all agreed that patients should have confined prostate cancer. Typically a PSA less than 10, some with a PSA less than or equal to 15, and all of them had Gleason 6 or less, so low-grade disease. There are a couple groups, Toronto group and Royal Marsden, that also included some patients, a little asterisk here, with some Gleason 7. Those tend to be older patients who may have a questionable long-term life expectancy. But additionally, there's a small number of positive cores, so 2 or less positive biopsy cores. Sometimes less than 33% of the core for UCSF, and Royal Marsden is less than half. And again, all of these were less than half of a core involvement, although there was some patient group that didn't report. In terms of follow-up strategies, I'm not going to go over this in detail, but let's just say it's very varied. So follow-up strategies could be a repeat biopsy annually. In Europe, they tend to favor longer follow-up, or in Canada. So in the Toronto group, it's every 3 to 4 years in the Toronto group. And at 4 and 7 years were repeat biopsies in the Prius group. So in the US, we are much more aggressive about following up with annual biopsy, or maybe every 1 to 2 years. And this in large part is because of our approach to management of people in medicine in the US versus around the rest of the world. We're much more worried about missing something small, potentially because of the litigation risk, than they are in places with a socialized healthcare system where it's more a focus on treating the most number of patients as appropriately as possible. So stratification is key. Patient selection. Surveillance is safe for the appropriate patient. And that is one of the things that I think we have seen, that with Gleason 6, there was a low malignant potential. There's a significant amount of data to support this. Gleason 6 does not meet the 6 classic hallmarks of cancer, so there was a debate at some of the AUAs for a while that we shouldn't even be calling Gleason 6 disease prostate cancer. We should call it something else. We still call it prostate cancer because it has enough of the hallmarks that we don't worry about, that we still consider it cancer. But then looking at patients who have prostatectomy, in a series of almost 10,000 patients who had Gleason 6 disease, with 15 years of follow-up, there are only 3 deaths. So granted, those men were treated. That's different than surveillance population, but tells you that patients with Gleason 6 disease is not aggressive disease. Similarly, in a physician's health study, no patients died of Gleason 6 or less disease with a prostatectomy after 2,600 person years of follow-up. That's, again, a very low malignant potential. So does Gleason 6 metastasize? The best evidence we have right now is that for patients with Gleason 6 disease, in a study looking at 14,000 men who had their prostate removed, there were no evidence of nodal metastases in all these men who had prostatectomy and then also lymph nodes removed. So of these 14,000 men, 0.1% did have metastasis, but when they went back and reviewed those cases, all of those men on review had a Gleason 4 component or higher in their prostate. So truly, if there's only Gleason 6, there seems to be really zero risk of metastasis. Now we'll talk a little bit later. Is biopsy detecting only Gleason 6? What's the risk of upgrade or undetected disease? So that's something you need to keep in your mind. I don't think we can ever tell someone that we have with a biopsy that there's no way they have metastases. None of us would ever do that, but it's a very low risk of that. So then looking at clinical trials. So with clinical trials, the PIVOT trial, initially published in 2012, it showed that radical prostatectomy did not reduce all-cause prostate cancer mortality through 12 years of follow-up. That has now been updated with 18 years of follow-up with the same results. There was no benefit in sort of prostate cancer specific or overall survival in men treated with surgery versus those who were observed. Looking at the, and you can see that here, both in death from any cause and from prostate cancer, no statistically significant difference. There is some variability depending on the risk and the PSA, but again, overall, there was no difference in surgery versus observation. There are obviously some caveats to this. The VA population is a little bit sicker than the national population. But when looking at the PROTECT trial, which is another randomized trial, PROTECT is in the UK. They randomize men to surgery, radiation, or observation. And in that trial, there was no difference in prostate cancer specific survival at 10 years, 0. These are 3 completely overlapped lines, p-value 0.48. So these are the same overall survival. So really there's no difference in men who are treated versus not treated. And, come on. However, there is significant morbidity associated with treatment. In the PIVOT trial, which was surgery only, there's definitely an increased risk of urinary incontinence and erectile dysfunction. There was not any significant change in bowel function in a surgery cohort. But when we look at the PROTECT trial, again, with no difference in survival, there is worse erectile function in men who are treated with surgery or radiation. There is worse incontinence in men who are treated with surgery. And there is worse bowel function in men who are treated with radiation. So any treatment that we have has side effects. So we want to try to avoid those treatment side effects whenever we have the opportunity. As a result of these findings and the interest in active surveillance, trying to minimize that, there has been an increase in the use of active surveillance for low-risk men. So this is based on using the CAPRA grade. Unfortunately, most of the data that we have is really only through 2013 or even 2015. In 2015, these rates have gone up even more. I think nationally now, I wasn't able to find the paper, but I think that active surveillance rate penetration nationally is over 60%. I don't know if Dr. Lietman knows. I can't recall. I've seen it in presentation, but I haven't seen it in published form. But I think it's close to 60% for national penetration of that now. For high-risk disease, obviously, active surveillance is not necessarily appropriate, and we don't see a high rate of that. But in low-risk disease, it is increasing temporally. It appears to also be safe long-term. So these, again, are some of those long-term studies with long-term follow-up. We can see the median follow-ups here range from about 1.5 years to 6.5 years in the Sunnybrook or Toronto data. Number of men who have progressed to treatment varies between 15 and 38%. So still, the vast majority of men with long-term follow-up remain on surveillance, meaning that they have not had progression of disease. Prostate cancer-specific mortality remains very low in these cohorts. The upper number, the 2%, the only one that's sort of close to that is the Toronto or Sunnybrook group, and that's because they included men with Gleason 7 disease and higher PSAs. So in the Hopkins group, which is confined to very low-risk patients with Gleason 6 only, low volume, their 10-year and 15-year prostate cancer-specific mortality is 0.1%. So do we want to be biopsying our patients annually and only including very low-risk patients? Not necessarily, but it is achievable to have a very, very low prostate cancer-specific mortality if you are very selective. So one of the challenges is figuring out what is the appropriate risk tolerance or risk threshold for this. We discussed earlier that one of the reasons that CLOTS trial, the Toronto group, has a higher rate of death. I mean, you can look here, PSA greater than 10 is one risk factor. So there's, even that has a higher freedom from metastasis than when there's Gleason 7 disease. So if there's any Gleason 7, there's a significant increase in rate of metastasis occurrence. And this is something that we're still kind of figuring out how can we include some of those patients. But all Gleason 7 does appear to be a slightly higher risk. When looking at, this is a recent publication from Patel et al. At Hopkins. They looked at the NCDB, looking at over 100,000 men. And they looked at a low-risk group, which they defined as grade group 1, clinical T2A or less, and a PSA less than 10. So in these Gleason 6 or grade group 1 patients, there still is a proportion with adverse pathology. And one of the things to keep in mind, and I didn't put it in all of the slides, but you have to know what people are defining as adverse pathology because it differs, and especially now. And so these are patients with seminal vesicle invasion, grade group 3 or higher, or lymph nodes. This is not clinically significant disease. This is something that we consider to be adverse pathology, or really true high-risk disease. So even in patients with what we consider low risk, low grade prostate cancer, if they go to prostatectomy, there still is about 7% of those people can have adverse pathology. No, this is pre-MRI. Yep. So this is pre-MRI, pre-MR fusion biopsy. We'll see, though, that MRI is not perfect either. MRI misses 10 to 14% of lesions. So, but again, it's not actually adverse pathology. That's clinically significant disease. So we'll talk about that a little more. But there's a clear increase. So from right to left, we have sort of increasing risk factors, with this blue, or 21%, being patients with full intermediate risk disease, where they have grade group 2 disease, so Gleason 7, clinical T2B or less, and a PSA of 10 to 20. So in that group, it's clearly the highest risk of adverse pathology, in around 20%. The difference here in the middle, as an increasing number of sort of intermediate risk factors with otherwise low risk disease. And there are different definitions which we can look up. But I think the important part of this is we can't remove all adverse pathology, but we can try to identify those patients who have a lower risk of having adverse pathology. We recognize that our current diagnostics are not perfect. We really worry about in active surveillance these undergraded cancers. So is a higher grade cancer missed on initial biopsy? And it often is. We know that with a typical trust-guided 12-core biopsy, you miss 15 to 40% of prostate cancers. All you have to do is do another 12-core biopsy, and you can detect up to 40% of those patients will have a higher grade prostate cancer. Similarly, in these low-grade cases, or patients Gleason 6 on biopsy, up to half of them have higher grade disease on radical prostatectomy. These, again, are historical, and so we're going to talk about some ways to increase our specificity with this. And are some of these low-grade cancers worse than others? Again, how do we determine this? We haven't been able to figure it out based on PSA and Gleason score, but maybe we can improve our risk stratification using genomics and MRI. And bringing those together may be complementary to help us work together and increase our stratification even better. So in genomics, the three main genomics, I'm not going to talk about sort of the second generation blood tests. I'll mention those in a little bit when we go over the EAU guide position statement. But genomics specifically, I'm going to talk about pathology genomics. And that's for the biopsy-based tests, Oncotype DX, the GPS score, and Myriad's Polaris score. All of these have been demonstrated in their validation studies to correlate with grade of disease and recurrence of disease. And we're using them quite frequently now in active surveillance to try to predict who may have worse pathology than we think. The Decipher score, for example, I'm going to focus mostly on the data for Decipher because this is some of the stuff that's published more recently, and that's also what we predominantly use here. Not to be too biased, but GPS and Polaris score both are relevant. They don't have as many recent publications in this area of genomics, but they do have a lot of other published data. It's just they're a little bit older. So the Decipher score does correlate with, you can see the Decipher score on the bottom here, and this is the how many patients. They're clearly Gleason 6, 7, 4+, 3, 7, 8, and 9, 10. So the peaks definitely move from left to right in terms of Decipher score tracking with volume and whether it's low, intermediate, or high risk disease. This is a study done by Eric Klein, and what they looked at are men with low and intermediate risk prostate cancer, so candidates for active surveillance, and then they stratified them based on adverse pathology, which was T3 or surgical margin positivity. And what they found is that in patients with Gleason 6 disease, clearly those with a T3 or surgical margin positivity had a higher Decipher score, so a higher genomic score. Interestingly, those with Gleason 6 but a higher adverse pathology risk had a higher average Decipher score than patients with a higher Gleason grade and lower adverse pathology risk. So the genomic classifiers are more precise for metastases and adverse pathology than Gleason score likely is. Now, how will this play out in terms of long-term follow-up and long-term biochemical recurrence? We're not sure, but we are definitely seeing that it is a better predictor of adverse pathology. What do you mean? It can be. It can be. I think I agree with you. That was my question as well. I mean, I would have preferred they use node positivity since it's actually a test for metastasis. I think the risk thing is that the metastasis risk is so low in this population that they didn't have any data for that. Margin positivity is a risk for requiring additional treatment, though, in terms of the adjuvant setting for radiation. So it is considered a high-risk feature. Is it necessarily a reflection of the disease? I agree with you, not necessarily. How often? I defer.
Yeah, it's like 5%. It's like these are these,
Yep.
very high PSA.
Correct. Yeah. No, you're right. So it's not as common, but if we can identify those patients, we would like to, right? So we'll talk a little bit later about some risk stratification tools that may be able to help identify some of those patients, maybe. But no, those are good points. I mean, I think in reading the literature, those are things to definitely look at. Where am I supposed to point this? Because it doesn't. There we go. All right. So the GPS score was also recently reviewed. So Egner et al. Published their series. This is where they use the GPS score to help triage patients whether or not they should have surgery or stay on surveillance. There were almost 800 patients that had this process, and then over 100 patients ended up going on to have surgery as a result of that. What they found, I think the kind of most relevant thing here is that adverse pathology very clearly tracked with NCCN risk groups, a very low, low, and intermediate, with an increasing risk of adverse pathology, with a very low number of adverse pathology in the very low risk group. And the argument of this paper is that by utilizing the GPS score to help stratify these patients, we were better able to identify those who were truly at risk of having adverse pathology, because there were a large number of those in this area. To find statistical significance for a GPS, they had to bump it by 20 units. That is a huge jump for the GPS score, so I'm not sure that's necessarily really useful as a cutoff or a comparison. I think overall what we're seeing is that these tests are being validated and used such that a higher GPS score, higher Decipher score, higher Polaris score clearly are associated with an increase in risk in higher grade disease. That was done in a biopsy sample, correct. Yeah, so this is biopsy correlating, not predicting, but correlating with final pathology. When looking at the Decipher score, looking at men with low or intermediate risk disease, this was a study about 112 patients. By using the genomic stratification, they were able to predict who would have a risk of, again, as you made point earlier, Bruce, this is a small number of people overall, but using this helps us stratify who is at the higher risk. And in the high risk group, almost 1 in 3 patients were at risk for metastasis. And that clearly is someone who we would not want to include in a surveillance cohort. With that historic data in mind, Dan Spratt out of Michigan, and I believe it's a multi-center group, they wanted to integrate the NCCN risk criteria with the Decipher genomic risk classifiers. This is getting more to how we could potentially use this on a daily basis when we're talking with patients. They had an identification and a validation cohort of 235 pre-treatment biopsy samples. All those patients ended up being treated with about half of them having prostatectomy. And then 756 separate radical prostatectomy specimens. They then used this in 2 reclassification cohorts to see how it played out. So the kind of simplified version, if patients have low NCCN risk group, so low risk disease, favorable intermediate, unfavorable intermediate, or high and very high risk disease, you can get a point for each of those. So low risk is 0, favorable intermediate is 1, unfavorable intermediate is 2, and very high is 3. Similarly, Decipher low risk with standardized cutoffs 0.45, intermediate 0.45 to 0.6, and Decipher score greater than 0.6 is high risk. By tiering these into low, intermediate, and high risk, they were able to generate composite scores that predicted 10-year metastasis risk. So someone with a low NCCN risk and a low genomic classifier had a 0 10-year risk of metastasis. There's a little bit of variability here because you can have someone with an intermediate risk score but low NCCN, so someone with Gleason 6 but they have a little bit higher Decipher score, they still would be in the low risk group and seem to be very safe from having metastasis. So I think what this illustrates is one test alone is probably not enough if everything else looks low risk to bump the patient into a treatment category. But if you start having multiple factors that are concerning, and this goes back to that pathology slide from the NCDB, where multiple factors being high risk may be concerning. These, this group of patients, I think very few of these, again, were MR targeted biopsy. So some people would still only select it for the low risk group and not necessarily for favorable intermediate. Not everyone's putting favorable intermediate on active surveillance. I think this is supportive of someone with a favorable intermediate and a low Decipher score is safe to have on surveillance. Whereas if you have an unfavorable intermediate or favorable intermediate and intermediate risk Decipher score, that patient probably shouldn't be on surveillance.
Diminishing the cohort of eligible people for you're not this test
Correct.
isn't going to put more people into active surveillance. If anything, you're going to be
Correct.
I guess more confident in saying you'll probably do okay on that.
Well, it depends on how you integrate it.
One thing also that, I mean, keep in mind, this is also calibrated to patients who were treated, right?
Right.
This is not TenYear. This is, I think, TenYear follow-up after treatment.
So this is all, yeah, so everything I'm presenting right now is patients who are not necessarily on active surveillance. These are patients who had surgery, retrospectively were found to be Gleason grade group 1 or group 2, would currently be active surveillance candidates and had surgery. So none of these are actually a prospective cohort of patients on surveillance. So there is now one study, and I'll present that, which has looked at these in a prospect and predicting progression. And we will maybe get there. Yeah.
Question is, how reproducible is Decipher? So I have a guy who is low risk. He's got nothing on MRI. He's had multiple biopsies, one focus Gleason 3+3, but he's high risk Decipher. And so we present him to him board. He's going to be re-biopsied with another MRI guided biopsy. Should the Decipher be repeated as well?
Absolutely.
So there's a lot of variability.
So there is heterogeneity. I don't present it because it hasn't been published. It's been presented. There's a fair bit of heterogeneity within the Decipher test. So the group in Miami were fortunate enough to get grandfathered in with their R01 to have, they would do 5 targeted biopsies like we do for, of a tumor, and they did a Decipher test on each of those. And there was a fair bit of heterogeneity, even within the tumor, on what the Decipher test was. I mean, the Gleason score varies in those tumors, but also the Decipher test varies. So there is heterogeneity. I've had patients on surveillance who have had a high Decipher score, later come back as lower on a second one. Is that because the cancer is different? Is because, I mean, we don't know. We don't have any Decipher to Decipher testing. Those are one of the questions that we hope to answer with some of the research that we're doing. So then applied the stratification tools to patients who had prostatectomy or biopsy, and in the combined groups, they validated that, and again, proves, as you mentioned, these are patients who we kind of are sub-selecting the very low risk, so it's not actually increasing our number of patients. We're trying to be more confident in who we're saying are very safe to be on surveillance. And that's really the purpose of this tool. But those patients who were in the low risk group with a combined study had a very low risk of metastasis out to 15 years and a very low risk of prostate cancer specific mortality. So this was very recently published. This is again, this is prospective at patients who are on active surveillance who then progressed. This is based out of Cedars-Sinai. It just was published in December. And they again found that patients who had an absence of adverse pathology had a lower Decipher score versus those with a higher Decipher score. the area under the curve is not significantly better than Decipher alone when you combine Decipher and CAPRA, but it is better than CAPRA alone. Again, their definition of high-grade disease is really adverse pathology. It's not clinically significant. This is really bad disease. So these are the patients that we're trying to avoid. I think what was interesting and helpful about this study is they defined negative predictive values at different cutoffs. And so they found a 91% negative predictive value with a cutoff of 0.45. So what we traditionally would have is the low risk group, and then they substratified that to an even lower, a cutoff of 0.2, which had a 96% negative predictive value. That means 4% of patients under this cutoff of 0.2 we'd be able to safely say have a 4% risk of having really high grade or adverse pathology. Now, the problem with using cutoff as 0.2 is that you exclude about 67% of the people who would otherwise be on surveillance. So it's definitely, this is not a way of including more patients. This is a way of being more precise and being more confident of who you can say is safe to have on surveillance, and potentially we can follow less frequently. That's the way that I see these tests as being most helpful. They're not telling us who really has really bad disease, but they're telling us who is safe to potentially follow on with less frequency. And we'll get to that at the very end. I'm excited about genomics. I think they are really allowing us for improved stratification, identification of high-risk mutations. Looking at these studies, these are just a heat map with risk of adverse pathology on this little x-axis here, or sorry, y-axis. And as you go from left to right, there's an increased genetic signature. This is the Gleason score, darker is higher grade. So those things clearly correlate. And we're seeing that specific genes seem to co-locate with these higher grade disease. We've kind of known this, but genomics is really bringing this to the fore. And very recently, this German group published a study looking at the molecular characteristics of prostate cancer in young men who were diagnosed with prostate cancer, and really finding some of the early driver mutations that are relating to prostate cancer. And they were able to develop a framework to predict the order of somatic alterations that will result in certain clinical outcomes. So I think this is where we're going with genomics, to really be able to personalize and look for those early mutations and see where things are going to happen. So in summary, sort of genomics on a broad scale, which isn't necessarily really applicable or helpful, but increasing genomic scores in active surveillance patients correlate with higher grade disease, higher risk of adverse pathology, and higher risk of metastasis. So if they have a high score, we probably shouldn't be following those patients on surveillance. We're still kind of gaining confidence in the active surveillance because all of these tests were designed in patients with whole mount pathology, so not necessarily active surveillance populations. So genomics may be more powerful predictor of adverse pathology and metastasis risk than grade group or PSA alone. So I think we really need to pay attention to these genomic scores. It's still early. We don't have a lot of studies, but there is a suggestion that it may be more predictive and we maybe need to give it more weight. So traditionally we said, well, Gleason 6 is how we're defining this. It may be that we really want to be using a genomic cutoff to define who should be in a low risk group rather than the Gleason score. We're still combining all of those because the combination seems more powerful. But we may be able to streamline that test soon. Now, looking specifically at the Decipher scores, less than 0.2, so in your patients, when you see these scores, appears to be predictive of very low risk of adverse pathology. Those patients seem very safe to monitor on active surveillance. I think a score of less than 0.45 is still predictive of favorable outcomes overall on surveillance, with a 91% negative predictive value for adverse pathology. That's actually still a very low risk. And then combine this with NCCN can predict freedom from metastasis, but again, that's really subselecting patients, not increasing our pie, the size of our pie of who's on active surveillance. Well, let's transition now to MRI. So we're pretty well versed in MRI, as you guys have seen before in my talks. I credit Patrick Walsh for really inspiring me to be interested in MR. And I think it has been one of the greatest impacts in our field. I think that's now that mantle is now transitioning to genomics. But MRI definitely for the last decade has been a major driver, and I think will remain to be very important. I'm gonna go through this quickly because I think you guys know most of this, but MRI uses anatomic and functional imaging to match that to whole mount pathology. We've seen that, we biopsy that. We can identify lesions that are in the anterior part of the prostate or away from what usually is sampled, which allows us to increase our accuracy of prostate cancer detection. We see this in correlation with the PIRAD score. So PIRAD is how we grade MRIs. With a higher PIRAD score, a higher concern that prostate cancer is present, we do see significantly higher clinically significant prostate cancer detection. Our results here at Yale, we recently updated this through last year. We're looking at over about 1,200 patients. We definitely see a higher cancer detection rate in our targeted biopsy group. We see a lower miss rate of cancers by including targeted and systematic biopsies. If we had not done the targeted biopsies, we would have missed about 30% of clinically significant cancers. That being said, the targeted biopsy is very good, but targeted biopsy alone would still miss about 12 to 13% of disease. So combining a targeted biopsy and the template biopsy is still very important. Some patients may, to digress for 1 second, some patients may say, well, I just want the targeted biopsy. I think it's very safe to say that our institution, there's about a 13% chance that you're going to miss a clinically significant cancer if you do that. The other reason that I personally think it's important to still do the template biopsy is if someone would potentially be interested in focal therapy, that's going to be required to have a template biopsy to make sure there isn't one of those other cancers. So if they're considering that, they need a template biopsy. So looking further at our data, I think it's one of the very important things to recognize is that there are 3 different patient populations, active surveillance in yellow, prior negative biopsy in purple, and our biopsy naive group in the black over here. Active surveillance, so green is low-grade disease, red is clinically significant, and blue is benign. As we can see, the active surveillance group, there's a high number of patients with low-grade disease, and that makes sense. We know these patients have prostate cancer. So, right, they are definitely more likely to have prostate cancer. But we clearly see a migration from left to right as the PIRAD score increases with a higher detection of clinically significant cancer. Between the patients that have a prior negative biopsy and those with biopsy naive, they're pretty similar, but patients who have never had a prostate biopsy before have a higher cancer detection rate, which also makes sense. They've never had a biopsy, they've never had a negative biopsy. But surprisingly, there's still a large number of patients who have had a prior negative biopsy who we are detecting prostate cancer in, especially those with a higher Gleason, or sorry, a higher PIRAD score. Getting into the active surveillance, MR fusion biopsy increases upgrading from systematic biopsy alone. So the NIH group published this earlier, and when you look at it by Gleason score, their number of cancers missed by a 12-core biopsy is almost 30 patients in this group had their higher grade cancer missed by a 12-core biopsy, whereas only a fraction of high-grade disease is missed by a targeted biopsy. You can see that as the Gleason score increases, there is less that is missed by a targeted biopsy, whereas it's relatively stable with a random 12-core biopsy. Looking at our data here, similarly, the red are where targeted biopsy only detected cancer. That means that these are cases where a systematic biopsy would have missed clinically significant prostate cancer. So even at low PIRAD score, half the lesions would have been missed. Half the clinically significant cancer would have been missed in an active surveillance population if we did not do the targeted biopsy. Conversely, if we only did targeted biopsy and did not do a template biopsy, half of the prostate cancers would be missed in patients with a PIRADS 2 lesion. Now that percentage decreases as we go up with a PIRAD score, but I believe that systematic biopsy is still needed along with targeted biopsy, as we do miss a fair bit of. Correct.
And so, is there any? Putting your head in the sand, is that a bad thing? Like not finding that Gleason 6 disease and not diagnosing the patients with prostate cancer, not putting them on active surveillance, saying you're negative.
That is a very good point and completely out of the scope of this presentation, but I agree with you completely.
Well, I mean, that's just, it seems like if you did not do the templated biopsy, you would be missing those.
Correct, but these are patients who are already on surveillance. So you're taking a step back on the initial diagnosis. Right, so on the initial diagnosis of prostate cancer, could we? So that is the precision trial, basically was meant to answer that. And it found they were able to avoid 24% of biopsies, and there was a decreased detection of low-grade prostate cancer. I think that that is still debated internationally on if that should be the standard of care. They are moving towards that in some places. Why don't I move to my next slide, because I think that's going to go along with that discussion. So if patients have a negative MRI and they have a high likelihood of having a negative prostate biopsy, should we be doing a biopsy? And so this is for all patients. So this was published by Amanda Liu, one of our medical students who actually just matched in ophthalmology at UCLA. So she ended up going to ophtho, but she did very well in the match. So looking at our entire cohort, and these were our first 100 patients with a negative biopsy, we found clinically significant cancer in only 3%. And this, again, is stratified by those 3 groups. In an active surveillance group, there is still clinically significant cancer, but it's about 7% of the time. Rates of negative biopsy in our group at this time, it was 100%. I think it still is that way if we have a true good negative MRI. Now, how do we do this? So biopsy naive, so 97% negative predictive value. Nationally, it's about a 10 to 13% negative predictive value. I tell people that there's about a 10% risk that they would have a clinically significant cancer. If they don't have other risk factors, and so we're kind of jumping ahead, but there are other things that we probably should include in our decision making. And there's actually a great study looking at negative MRIs from Panebianco in Italy, where they looked at patients who had a negative MRI and what happened to them on subsequent MR and biopsy. So in patients who had previously had a biopsy that was negative, that's this orange group, they had a higher freedom from detection of any prostate cancer over time than those who had never had a prostate biopsy before. So basically, again, weeding out the groups that already were selected for the Gleason 60. We're looking at clinically significant disease, however, those 2 curves are pretty much the same. And only about 5% of patients ended up having prostate cancer detected if they had a negative MRI. And then on subsequent MRI and targeted biopsy, if anything was detected. So, so the risk is low. The risk is low of finding high-grade disease if someone has a negative MRI. So maybe we shouldn't biopsy those patients. The question is really for exactly that rationale. If we don't want to detect the 30% of patients who have Gleason 6 disease and put them on active surveillance. This is something I'm discussing with Jeff Weinreb. He thinks that we should be one of the pioneers in this and stop biopsying negative MRIs. I am not convinced that I feel comfortable with that yet. I think the numbers are pretty good, but I think it's really a patient's personal decision. And if they're willing, and all of this is about a patient's risk tolerance. Like, how much insurance do they want to take for their life moving forward? I mean, are they willing to tolerate a 10% risk? Are they willing to tolerate a 5% risk? What does that actually mean? And so it gets to a long conversation. So in this group, what were the predictors for having clinically significant cancer detected? So a PSA density was very predictive, and age, so younger age was protective as well. And so what they recommend is that if PSA or PSA density is low and they have a negative MRI, then surveillance PSA and avoiding biopsy surveillance MRI may be reasonable. So again, these are patients who've had a negative MRI and not necessarily a negative biopsy, but I think we have to incorporate other factors in. And a negative MRI by itself, I think, is inadequate. And I think that's the main reason that I feel uncomfortable doing it, is by itself it's probably not appropriate. 0.15. So they actually just looked at, I think they looked at it as a continuous variable. Let me see here. I apologize, John, I don't remember. Yeah, I don't remember. 0.15 is a reasonable cutoff at this point. 0.16. Yeah. So when they then looked at what are the clinical characteristics of these patients that had clinically significant disease, there are a variety of things. I mean, many of them had Gleason 3+4, 4+3. A few had Gleason 8 disease. But interestingly, I think one of the things is a predominant cribriform, lesions were small, or a mucinous adenocarcinoma. And we actually know that this cribriform pathology is not visible on MRI, with only 17% of cribriform prostate adenocarcinomas being visible on MR. So MR does not detect everything. There are definitely limitations to what MR can detect. But that was just negative MRI alone with no biopsy. In patients who've had a negative MRI biopsy, so they've had the MRI and then they have a biopsy. So this could be any level of PIRADS. So this is usually if they've had an MR fusion biopsy, they have a lesion that's visible. But looking at MR plus biopsy, those who've had a positive fusion biopsy had a much higher failure rate than those who had a negative fusion biopsy. So an MR targeted biopsy, this is the rationale to do an MR targeted biopsy at least once, had a 60% reduction in the risk of Gleason grade progression on surveillance. And again, this is a group of patients who are already on surveillance. So they have been diagnosed with Gleason 6. So it's, again, not necessarily addressing the question of should they have a biopsy initially. But having a negative biopsy significantly reduces their risk of progression on active surveillance. So who does progress? Well, patients with a positive biopsy, but also those with higher grade disease. So we're starting to expand our criteria of who can be on active surveillance. We include Gleason 6 patients, some Gleason 7. This is the UCLA group, and what they found is that patients with any 7 had about a 23%, 24% annual reclassification rate. They then combined this with PSA density, and Gleason 6 with low PSA density used a cutoff of 0.15. Had the lowest rate of reclassification. Gleason 6 with a PSA density greater than or equal to 0.15 was next, et cetera, and then Gleason 3+4. The hazard ratio are here. So if Gleason 3+4 disease was present on initial biopsy, there's a 4.5% hazard ratio. If the multi-parametric MRI grade was a 5, or the hazard ratio was 5. And PSA density was in there, but it was not as high of a hazard ratio as Gleason 7 presence, or even the presence of a PIRADS 5 lesion. So predicting who these patients are is complicated. There's work on nomograms. This was a single center, single institution nomogram. We've sent them our data to use as well to kind of validate their nomogram. I think that's submitted somewhere for publication. AUC of 0.84 is pretty good. Trying to figure out how to make these really user-friendly and easy, though. Right now, it's not. It's really only been used in single centers. Something that might be easy is combining PSA density and MRI score. This study out of Japan looked at a very simplified PSA density cutoffs of less than 0.15, 0.15 to 0.29, and greater than or equal to 0.3. And then they grouped the PIRADS scores in 1 and 2 as low, 3 as sort of average, and 4 and 5 as high. And then stratified patients a low, moderate, and high risk. So you can kind of see high risk is a high PSA density, or patients with a high PIRADS score and an intermediate or high PSA density. And what they found actually was by doing this, those predicted significant cancers was very predictive of patients who would have a significant cancer detected on biopsy. It kind of makes sense. It's simple. It's a two-step process. I think that's a very reasonable thing to kind of use in clinical practice when looking at MRI and PSA density. So MRI summary, MR ultrasound fusion biopsy improves patient stratification. This is really key. So it's really the stratification. The initial MR ultrasound fusion biopsy allows us to really identify which patients are at risk of progression or not. Negative MRI is associated with lower progression rates on follow-up, both on negative MR and negative MR biopsy, although we still do miss some clinically significant cancer. Negative MR fusion biopsy has a 60% lower progression rate, so these might be folks that we can consider spacing out in their biopsies, and high-grade cancers have higher rates of progression. So let's combine these. Let's see, 6 minutes. Sorry, it's taking a while. So lots of fun stuff to talk about. The Decipher score is something that we evaluate. This is Daryl's right here, lead author on this. It just got published. So we compared our Decipher score with MRI, and in this group of about 100 patients, we found that those with grade group 2 disease had higher Decipher scores than those with grade group 1. And you can see that here at per PIRADS, that was true across especially PIRADS 4 and 5 disease. And looking at grade group 1 and grade group 2, with grade group 2 disease, there's a higher rate of average and high risk disease compared to low than in grade group 1. This was just trying to assess what, is there a correlation between Decipher and MRI, and there does not really appear to be. This is very early. We are very interested in having subsequent biopsies and seeing how, if either of these predict progression. We were not able to show that in this study. However, this published a few weeks ago looked at the GPS score combining with PI-RADS and whether or not it was able to predict progression in patients with serial biopsy. This is out of the UCSF group. And so patients had to have Gleason 6 disease on biopsy prior to upgrading or surgery, and PI-RADS, MRI, and the GPS score. So they actually had 3 different cohorts they looked. They had patients who had a GPS only, which is about 140 patients, people with an MRI only, which is about 170, and 130 patients with both a GPS and a PI-RADS. So that's important because the results differ depending on what you had. In the cohort that had both studies, the GPS score and the PI-RADS score, similar to ours, don't seem to really correlate. So we know that MRI is very predictive in patients with high-risk disease when it's an initial biopsy. In our active surveillance population, where we're dealing with patients in general who have low-risk cancer, MRI doesn't seem to necessarily be as useful. Again, it's because we have low-risk cancer patients here. MRI is very good at finding the high-risk disease, but when we take this cohort of patients who are predominantly low-risk, it's not as helpful. Looking at this is a GPS score. The red is patients who progress. The blue is those who did not progress. So it's much, in this waterfall plot, much more red on the right side. As the GPS scores go up, more patients were progressing on active surveillance. So they found statistically that with each 5-point increase in the GPS score, the hazard ratio is 1.28, so the 28% increase in risk. With the higher GPS score or PI-RADS, either one of those, or PI-RADS 4 or 5, was associated with increased risk of biopsy upgrade. However, when you look at both of those together, only the GPS was predictive, was independently associated with biopsy upgrade. So in this study as well, it appears that the genomic markers in an active surveillance population may be more predictive of progression or upgrading, or at least correlate with Gleason score. Yeah. So there just aren't enough patients yet. So we're asking that question. I think we have. Do you remember, Daryl? I know we have one patient who had a low Decipher score, had a low Gleason score, had a low PI-RADS, and ended up having higher grade disease. We found out that he had Gleason 7 on his biopsy, but we ran the Decipher score on his Gleason 6 disease. So maybe there's some heterogeneity there. There just aren't enough cases yet. So we think we now have over 200 patients with a Decipher score. This is off our first 100, so we're actively trying to look at that. So very limited data. So we just don't know. There are a lot of great questions I think we want to answer, but we don't have the data yet. All our patients with Decipher scores, yeah. You mean like everyone? Correct. Everyone who's had a Decipher score that's been sent through Yale, we have those. So in active surveillance, genomics appears more predictive of pathology and progression in early studies than MRI. And MRI and genomics do not appear to correlate. So they play well together, and they may provide independent, useful information, but they don't necessarily correlate, so they don't move in parallel. All right, so very quickly, EAU position statement of 2018. So in Europe, they feel that all men with low-risk disease should be considered for active surveillance, irrespective of the number of biopsies positive at initial biopsy. And this is different than the historically narrower inclusion criteria. I agree with this, especially in the era of MRI and targeted biopsy, because we really are stratifying those patients with higher risk disease. We previously used a higher number of cores of biopsy to be a surrogate for the likelihood of having high-grade disease that was missed. That no longer seems to be applicable. Still, patients with more cores present are at higher likelihood of progression. We have seen that in our data here as well, in early preliminary data. But all patients with low-grade disease should be eligible. We don't have to use that same criteria in the MR-targeted biopsy era. The role of MRI. So both targeted and systematic biopsies are recommended by the EAU, and this is because MR fusion biopsy should be recommended prior to enrollment in active surveillance. So if someone has a biopsy, instead of having a regular trust biopsy, they should have an MR-targeted biopsy because they're more accurate. Patients with a positive MRI are higher risk of progression. You want to know that. You also want to be able to, again, select out. We want to cull the herd and get only our really true low-grade prostate. And again, those are subsequently at lower risk of upgrading after an MR-targeted biopsy. Confirmatory biopsies include targeted and systematic sampling. Avoiding of the systematic misses 3 to 13% in the published literature, in addition to ours. With targeted classification in 2 to 22%, we see up to 20 or 30% in our series. Again, there's no robust published data to support the use or timing of multiparametric MRI instead of repeat standard biopsies. As we were talking about, MR probably can't replace biopsy unless the MRI is negative. And maybe in a subselect group of patients, MRI is negative, they've had low volume Gleason 6, they've had a negative MR targeted biopsy, their PSA density is low, maybe in that subgroup we can just follow them. Yeah. Don't know. Well, actually, Panabianco's, that was their 7-year follow-up study where they showed that negative MRI, which I presented, with a negative MRI, there was only about a 5% detection rate of clinically significant cancer. That's the longest follow-up to date. I think that's a 7-year follow-up. We don't know. We don't really know. So in the traditional literature, yes, we have looked at that and presented it and submitted it as an abstract. I think the data was a little weird because some of it made sense, some of it didn't. It did appear that peritoneal invasion was still a risk factor for upgrading, but only in the systematic biopsy cores, not in any of the targeted cores. And the Gleason grade that we found in the targeted cores wasn't predictive of upgrading either. So I'm not quite sure. If there's someone who has a lot of peritoneal invasion, I still think of it as a higher risk factor for progression, possibly. I don't think we have good evidence yet. Optimal surveillance schedule is not defined. The repeat biopsy within 3 to 5 years. So in Europe, again, they are much more lax with their biopsy, which I think needs to be reassuring for us that we can space out our biopsies to a little bit. We have their ongoing trials trying to answer what this surveillance schedule should be. So our trial here at Yale, and also there's a prostate cancer active surveillance trigger trial at Uppsala in Sweden. An important factor is talking with someone about this morning. There should be no upper or lower age limits. If someone is healthy, for younger men, Dr. Liebman can chime in later, but we should not be excluding these men from active surveillance. In fact, they have lower progression rates when they're younger and have lower rate disease than men who are older. The G8 or GeriAC 8 screening test is available online. It's a quick little thing you can plug some numbers into. If patients have scores greater than 14, they should be treated as anyone. 14 basically means you're walking, talking, have no limitations. You kind of know what's happening. You don't know if you've lost weight or not. You sort of are doing it on purpose. But if not, there's actually a very high 3-year mortality rate if patients are sort of frail or decrepit. But shouldn't do it based on age alone. So including Gleason 7 patients, it's really hard to tell. We're kind of trying to expand this. The Sunnybrook data, Royal Marsden, their active surveillance cohorts both had a much higher risk of metastasis and adverse pathology when patients who had Gleason 7 disease on surveillance. UCSF had no difference, but they only had 48 months of follow-up or 4 years of follow-up. We clearly see in pathologic studies, evaluations, that there is a marched up increased risk of adverse pathology and outcome occurrence less so, but adverse pathology as you go up with a percentage of Gleason 4 and the Gleason 7 prostate cancer. Really from 0, it's about 11%, and up to 10%, less than 10%, it's at 20% risk of adverse pathology. So I'm including those patients, but we're still figuring out how comfortable we are with that. I think that's an area where the genomics can play a very active role. So patient race should also not affect eligibility for active surveillance. Biomarkers appear interesting, but there's really no robust data. So PHI, maybe if the score is greater than 76, they're at higher risk. PCA3 and TMPRSS2 ERG had no additional value. 4K, helpful initially for reclassification, but no real benefit on surveillance. And genomic markers, as we just talked about, there's growing data, but they need to be more widely validated. Really, in that Gleason 3+4 group, it can be reassuring about non-intervention if they have a lower Decipher score. So I think, I'm feeling less comfortable with the Gleason 7 patients unless they have a low genomic risk, as I'm sort of reviewing all of this literature now and thinking about this more. So can we safely expand our active surveillance inclusion criteria? I don't know how we can necessarily do that. There's some mathematical models which have looked at patients eligible, so the patients who include Gleason 7, so Toronto and Royal Marsden, they have a lot of patients that are eligible, but they also have a very high rate of unfavorable disease at final pathology. and a high rate of grade group equal to greater than 4 T3B or lymph node involvement at greater than 2%. This is a mathematical model saying that, we can maybe try to optimize this. Well, what are acceptable risks? And for a given patient, it may be a different risk threshold than for someone else. So I think we're moving towards some personalization, having patients be able to say, well, what risk am I willing to take? They felt that this 18% threshold kind of optimized this with a 30% cancer detection rate, or 30% of patients included, and only 13.5% with adverse pathology. This was higher than Prius with a similar adverse pathology rate. Food for thought. I don't think that that's necessarily definitive. So very quickly, I'm sorry, I know we're over time. What I'm currently thinking about this, I don't have a tremendous amount of data, basically just what we've all seen here together with a little bit more experience, but I think anyone clinical T2, if there's T3 disease, they shouldn't be on surveillance. And that can be palpable or on MR. If on MR you see something clearly through the capsule or into the seminal vesicles, they probably should not be on surveillance. Grade group 1, I put in a sort of very low risk, PSA density less than 0.1, Decipher less than 0.2, IRADs 1 to 3. These are the guys who are very low risk, microfocal disease, people with indolent cancer we probably shouldn't have detected. These guys, I think we should be biopsying after an initial confirmatory biopsy every 2 to 3 years. So I still recommend initial diagnostic biopsy, a repeat biopsy at 1 year just to confirm. But then after that, I think every 2 to 3 years for biopsies for people who have either negative MRI, negative second biopsy is very reasonable. This low risk group, this is the guys with a higher volume Gleason 6. PSA density still should be less than 0.15. Decipher score less than 0.45. Sort of any PIRAD score. And their biopsies every 12 to 24 months. This is where there's a lot of kind of noise. These are the ones we're not sure exactly how to manage. The higher risk group, Gleason 7, PSA density less than 0.2, Decipher in the average risk. Any one of these factors, I think, is probably okay to have them in surveillance. If they have multiple factors here, I'm starting to get uncomfortable. I think if they have Gleason 7, their Decipher score is 0.6, or their Decipher score is 0.58, their PSA density is 0.18. I mean, you start getting multiple high-risk factors. Those guys are the ones that have a high likelihood of progression. And I worry that they may have metastatic disease that we could miss. There's no data clearly to predict progression rates yet. This is what we're studying in our trial, and there's an ongoing trial in Miami as well, looking at including MRI, Decipher scores, and Gleason grading and active surveillance. The takeaway points for the talk, I think active surveillance remains a very important management strategy for our patients. It's safe for appropriately selected patients. Again, inclusion criteria are expanding, which I think this requires a more extensive discussion of risks and unknowns if we're going to include those patients with high volume 6 and low volume Gleason 7, because we don't know exactly what it is, and we're using some of these other things like MRI and genomic testing. MRI target biopsy is a very important part of active surveillance. I think it's MRI alone is not currently adequate, and target plus template biopsy should be performed in patients on active surveillance. So we don't want to skimp on those. And finally, genomic markers improve stratification. This does require further validation, but it may be more predictive than Gleason grade or PSA, and appears to be more predictive than MRI in the early active surveillance cohort results. All right, thanks, guys.